There is a time window between approximately 11 p.m. and 3 a.m. Cancer cells in your body multiply faster than at any other time during the 24-hour cycle. That is not a theory. It is a documented biological pattern confirmed by multiple independent research teams, and I'm going to walk you through the exact mechanism and protocol that targets it, not in months and not with a prescription tonight. The healthcare system profits from managing symptoms indefinitely rather than preventing the problem from occurring in the first place. I'd like to know where you're watching this video and what time it is. Please share in the comments section. Even a brief moment from your day is highly valued here. If you found this helpful, please subscribe to receive future gentle tips tailored to your needs. Nobody will explain what I'm about to show you during your next oncology appointment. Dr. Russell Ryder of the University of Texas Health Science Center published research that his own colleagues dubbed the most important mitochondrial protection mechanism we'd largely ignored for 30 years. His research, as well as the subsequent brother circadian oncology literature, tell a different story than what you would hear in a standard clinical conversation. Most people believe that cancer prevention involves what you eat during the day. According to the research, the most critical window is what happens to your mitochondria between 11 p.m. and 3 a.m. and whether the process is working properly or not. Your mitochondria are located upstream, while cancer cell multiplication occurs downstream, and almost no one measures the upstream variable. Not slowed down, not slightly inhibited, but stopped. Even people who eat a healthy diet, take their supplements on a regular basis, walk every morning, and have clean scans contribute to nighttime tumor proliferation. Because the issue is not what they eat, but rather a collapsed hormonal system that was designed to protect their mitochondria between midnight and 3 a.m. And after the age of 60, that system fails in a very specific and predictable manner. The villain has a name: melatonin-mitochondrial axis failure. I'll explain what that means and why it's the most underappreciated cancer risk factor among people over 60. But first, I'm Dr. I translate peer-reviewed research and document case patterns that appear throughout the literature, so you can see the evidence without the marketing. Before we continue, please note that this is educational information based on published research. If you are currently being treated for cancer or another serious condition, consult with your doctor before making any changes to your protocol. Now let's look at what your body was designed to do between midnight and 3 a.m. and what happens when that design fails. Your mitochondria are more than just power plants for your cells. You've heard the phrase, but here's what the metaphor leaves out. They are also the decision makers. When a mitochondrion inside a cell detects damage, DNA errors, oxidative stress, or metabolic dysfunction, it can signal the cell to stop dividing, repair itself, or, in the case of severe damage, destroy itself completely. The last mechanism is known as apoptosis. It is the body's self-cleaning mechanism. A damaged cell receiving the apoptosis signal is analogous to a factory worker discovering a critical error in the assembly line and shutting down the machine before the defective product is shipped. The machine has stopped. The line is inspected. Quality is maintained. This is what healthy mitochondria do. Cancer cells are cells in which the machine never shuts down. The apoptosis signal never fires. The damaged cell just keeps dividing, replicating the error, making more defective product over and over and over. The central question in cancer biology is why the mitochondrion in that cell stops sending the stop signal. What sets off the alarm? The answer, according to a substantial body of circadian oncology research, is one compound: melatonin. Most people believe melatonin is a sleep hormone. You take it if you can't sleep. If you take too much of it, it causes you to feel groggy in the morning. That is the drugstore equivalent of melatonin. The biological version is fundamentally different and far more powerful. When it gets dark, your body produces melatonin in the pineal gland, which then travels through your bloodstream and directly enters your cells, including your mitochondria. Melatonin performs 3 functions inside the mitochondria that are directly related to cancer. First, it neutralizes reactive oxygen species, which are oxidatively damaged particles that accumulate during normal metabolism and stress. Think of reactive oxygen species as sparks from a welding torch. If those sparks land on dry wood, they will start a fire. Melatonin is the fire suppressant that coats the wood. Second, melatonin activates a protein called BCL2 regulatory pathways, which determine whether damaged cells live or die. Third, and most importantly, Ryder's team discovered that melatonin directly supports mitochondrial membrane potential. The membrane potential represents the electrical charge difference across the inner mitochondrial membrane. When that charge is maintained, mitochondria function normally, quality control runs, and apoptosis occurs as expected. When that charge collapses, you lose complete quality control. The factory manager falls asleep. Defective product ships indefinitely. Here's what happens after 60. The pineal gland calcifies. This is not speculative. It is visible using standard brain imaging. By the age of 60, the average person's pineal gland function has decreased significantly compared to that of 30. According to some research, melatonin output drops by 60 to 70%. Think about what this means for the nighttime window, around 11 p.m. and at 3 a.m., when your body should be flooding your mitochondria with melatonin, running quality control, priming apoptosis mechanisms, and suppressing oxidative damage. You only have a fraction of the protective signal. The watchman is absent. The factory operates unsupervised, and any cell that was already on the verge of malfunction, any cell that had accumulated the types of DNA errors that healthy mitochondria should be flagging, gets a free pass through the night. That free pass, repeated for weeks, months, and years, is how subclinical cancer spreads quietly, not in one dramatic event, one unsupervised night at a time. Now I'd like to add another layer to this because Ryder's melatonin research is only part of the picture. A second mechanism, known as the Warburg Effect, works in tandem with melatonin loss after 60. Otto Warburg received the Nobel Prize in 1931 for discovering that cancer cells prefer to generate energy via a completely different pathway than healthy cells. Healthy cells generate energy through the mitochondria, which use a clean, efficient process known as oxidative phosphorylation to produce approximately 36 units of ATP from 1 unit of glucose. Even when oxygen is available, cancer cells use a different pathway known as glycolysis, which produces only 2 units of ATP per glucose molecule. This is incredibly inefficient. To meet their energy demands, cancer cells must consume massive amounts of glucose. Consider it like this. Imagine a healthy cell as a modern, fuel-efficient vehicle. 1 gallon of gas gets you 40 miles. A cancer cell is an old 1965 engine with a cracked fuel line. It gets 2 miles per gallon and leaks the remainder on the road. To travel 40 miles, it requires 20 gallons of fuel. That's why cancer cells are so hungry, they require constant glucose. And at night, when most people haven't eaten in 4 or 5 hours, when blood sugar should be stable and insulin quiet, any spike in blood glucose serves as direct fuel delivery to any cancer cells that are actively proliferating. What causes the Warburg effect to be especially strong at night? Cortisol dysregulation. Cortisol peaks at the wrong time in people over 60 with disrupted circadian rhythms, which accounts for the vast majority of published actigraphy data. Instead of the typical pattern of cortisol being lowest at midnight and rising toward morning, dysregulated cortisol can remain elevated or spike in the late evening. Elevated cortisol raises blood glucose levels. Elevated blood glucose at 1 a.m. When insulin sensitivity is at its lowest point of the day means glucose stays in circulation longer, making it available for cancer cell metabolism and fueling the Warburg effect machinery at precisely the time when mitochondrial quality control is already compromised by melatonin deficiency. Because the cascade is important, let me present the entire picture in order. Stage 1. Pineal gland calcification reduces melatonin production. Stage 2. Melatonin deficiency reduces mitochondrial membrane potential in susceptible cells. Stage 3. Quality control suffers when the membrane potential is compromised. Damaged cells are not targeted for apoptosis. Stage 4. Cortisol dysregulation raises nocturnal blood glucose levels. Stage 5. Cancer cells in the Warburg metabolic state use the nocturnal glucose surge as direct fuel. Stage 6. Through 11 p.m. to 3 a.m., these cells divide and multiply in an environment in which normal suppression signals are absent or muted. The entire process is a biological perfect storm that silently forms in your body every night, with the melatonin-mitochondria axis acting as the upstream lever, determining whether the storm builds or breaks down. A landmark 2009 study by the International Agency for Research on Cancer classified night shift work as a probable carcinogen, not because shift workers eat poorly or exercise less, but because chronic disruption of nocturnal melatonin production is enough to increase cancer risk. Stevens and colleagues' 2014 meta-analysis of more than 13,000 subjects confirmed this finding. Every 10% reduction in nocturnal melatonin was associated with a measurable increase in cell proliferation markers. These aren't my numbers, this is the published literature. And if you are over 60 and do not specifically protect your melatonin-mitochondria axis before bed, you are operating with the same level of reduced protection. Not because you work nights, but because your pineal gland has been gradually calcifying over the last decade or two. There is a third research thread that I want you to understand because it is directly related to the protocol I'm about to give you: mitophagy and autophagy. Autophagy is your cell's self-cleaning mechanism, where damaged cellular components, including mitochondria, are broken down and recycled. Mitophagy is the autophagy process that targets damaged mitochondria. Guido Kromer of Institut Gustave Roussy, one of Europe's leading cancer research centers, discovered that mitophagy rates in cancer-adjacent tissue are significantly reduced in older adults. What causes mitophagy? A compound known as AMPK, AMP-activated protein kinase. AMPK is a cellular energy sensor. When your cells detect an energy deficit, AMPK activates, resulting in mitophagy. Cleanup begins. Damaged mitochondria are recycled and new healthy mitochondria are created. The irony is devastating. The fasting state of a normal overnight sleep window, which lasts from about 8 p.m. to 8 a.m., should be sufficient to activate AMPK and promote healthy mitophagy. However, eating anything within 2 hours of going to bed, no matter how small, suppresses the AMPK signal. The cleanup crew is sent home. The damaged mitochondria, which should have been recycled during the overnight window, remain in the morning, carrying their compromised quality control function into the following day's cell division cycles. How many of your cells are dividing tonight? In an adult body, approximately 3.8 million cells divide every second. By tomorrow morning, hundreds of billions of division events will have taken place. Each of those divisions, in a cell with compromised mitochondrial function, in an environment of low melatonin, high nocturnal glucose, and suppressed mitophagy, occurred without full quality control. That's not a metaphor. That is the scope of what occurs in your body every night. 3.8 million divisions per second, unsupervised. Now I'd like to tell you about a case that I reviewed in the literature, one of those documented patterns that transforms the mechanism into a human narrative. I will call him Robert. He was 62 years old, a retired engineer from the Pacific Northwest, and he was discovered by a research team while searching an integrative oncology registry. He had been treated for early-stage prostate cancer 3 years ago with surgery, clean margins, and a PSA level that was nearly undetectable. Every standard marker indicated that he was in remission, but Robert wasn't sleeping well. He said it took him 30 to 40 minutes to fall asleep, and he woke up every day around 2 a.m. and lying there for an hour or so before falling asleep again. He felt tired in the morning. He informed his oncologist at each visit. His oncologist told him it was normal for his age and suggested he try sleeping pills. Robert declined. He wanted to understand why. He began meticulously tracking his symptoms, similar to how engineers log their data. He recorded his sleep and wake times, how he felt at 2 a.m., what he ate in the evening, and his morning energy level. He did this for 14 months. He saved 14 months of data in a folder and eventually shared it with an integrative oncology researcher who was recruiting patients for a circadian biology study. The data revealed a pattern that the researcher described as one of the most distinct circadian rhythm disruption signatures she had seen in a non-shift worker. Robert's 2 a.m. He woke up consistently in the evenings after eating within 90 minutes of going to bed. His wife insisted that even something small, such as a piece of fruit, a handful of crackers, or a glass of milk, would help him sleep. Every evening involved late eating, followed by a 2 a.m. waking. Every evening began with an early dinner cutoff 3 to 4 hours before bedtime, followed by a restful night of sleep. He had unknowingly been documenting his own melatonin disruption pattern in spreadsheet form for over a year. He had tried melatonin supplements, but only in sporadic low doses of 1 milligram here and there, which research suggests is insufficient for mitochondrial protection. He had tried chamomile tea, magnesium supplements taken at random times, and blue light glasses worn occasionally. He reduced his caffeine intake to before noon, which helped slightly. He had taken a short course of zolpidem, a sleeping medication, at the suggestion of his oncologist. It kept him asleep, but the next morning he felt cognitively impaired, so he stopped taking it after 2 weeks. He was pulling levers at random, with no understanding of the upstream mechanism. The pivotal moment occurred when the integrative oncology researcher reviewed his case files. She stopped asking how Robert was sleeping. She began inquiring about what was happening to his mitochondria around 11 p.m. and 3 a.m. She inquired about his eating window. She inquired about his evening light exposure. She inquired about his cortisol levels, which his primary care physician had never checked at night. A saliva cortisol test was conducted at 11 p.m. and 2 a.m. showed elevated cortisol levels at both time points. His evening cortisol was not dropping as expected. That elevated cortisol was causing late-night glucose elevation, which was suppressing his AMPK activation, resulting in his mitophagy window being closed every night before he could perform its function. After the upstream image was completed, the reveal was simple. Robert did not have any sleep problems. He had a nocturnal mitochondria vulnerability issue that manifested itself as a sleep problem. His melatonin-mitochondria axis was failing on 3 fronts at once. Melatonin production is reduced due to age-related pineal calcification, late eating suppresses AMPK and mitophagy, and elevated nocturnal cortisol feeds glucose to any cells in the Warburg metabolic state. In the context of a man 3 years after prostate cancer treatment, with PSA markers being closely monitored, the research team took this pattern seriously. The correction involved a precise sequencing intervention rather than a supplement pile, as well as a time protocol with 3 components. Over 6 weeks, Robert's 2 a.m. wakefulness decreased from 5 to 6 nights per week to 1 per week. Over 3 months, his morning energy level stabilized. At his next oncology appointment, his PSA level remained undetectable. Upon reviewing his chart, his oncologist discovered that his inflammatory markers, IL-6 and HSCRP, had dropped to their lowest recorded levels. His oncologist didn't ask what he could have done differently. That is precisely the gap this channel exists to fill. Everything I explained about the melatonin-mitochondrial axis, the Warburg effect, and nocturnal cortisol was exactly what was going on in Robert's body each night. He is not an outlier. Rather, he represents the norm. Now, before I give you the protocol, I would like you to do something right now while you are watching this. There are 2 tests you can perform in the next 60 seconds to learn about your nocturnal stress physiology and vascular status. The first one is a temporal pulse test. Press 2 fingers lightly against your temple, which is located on the side of your forehead just in front of the ear. You should feel a faint, regular pulse. Feel that for about 10 seconds. Now I want you to notice something. Is the pulse steady and calm, or does it seem tense? A temple artery that is noticeably firm and resistant to gentle pressure, which physicians refer to as a high-resistance quality, may indicate elevated sympathetic tone. That elevated sympathetic tone at night is precisely what maintains nocturnal cortisol levels and prevents the parasympathetic shift that allows melatonin to peak. You're not diagnosing yourself here. You are collecting a single data point. File it. Second test. Sit quietly for a moment. Close your eyes halfway. Consider whether you are truly drowsy right now, if it is after 9 p.m., or if your mind is alert, restless, and still working through tomorrow's tasks. That level of mental alertness late in the evening is one of the most obvious behavioral indicators of disrupted circadian melatonin timing. Starting around 9 p.m., healthy melatonin onset causes a very specific subjective sensation, a warm, heavy, slightly blurred quality in your thinking. If you consistently feel alert and awake around 10 or 11 p.m., if you have difficulty sleeping, your melatonin onset is most likely delayed, which means the window of peak mitochondrial protection is also delayed, compressing the most critical autophagy and quality control window into the few hours before your alarm. This is not a minor inconvenience. That represents a structural reduction in your cancer cell quality quality control cycle. Let me show you a picture so you can see what the difference looks like in the same person. Consider two versions of a 65-year-old man. We will refer to both of them as the same baseline. The diet, exercise routine, and cancer history are all the same. Version A eats dinner at 8:30 p.m., drinks a glass of wine at 9 p.m., watches television with overhead LED lighting until 10:30 p.m., then retires to bed. His insulin level at sleep onset remains elevated. The alcohol and light both suppress his melatonin production. His AMPK never activates. His bedroom is 72 degrees because his wife prefers it warm. His nocturnal cortisol levels at 2 a.m. would most likely be in the upper third of the reference range. His mitophagy window has closed. His mitochondria function unsupervised from midnight to 6 a.m. Version B, the same man with the same genetics, eats dinner at 6:30 p.m. and then doesn't eat again. At 9 p.m., he dims the lights, switches to a warm lamp, and closes any screens. His bedroom temperature is set to 66 degrees. He takes magnesium glycinate at 9:30 p.m. and melatonin at 10 p.m. when he retires to bed. His insulin had cleared by 9 p.m. His melatonin levels begin to rise at their natural onset time. His AMPK activates during the first few hours of sleep. His mitophagy completes its full cycle between midnight and 4 a.m. His cortisol levels at 2 a.m. are appropriately suppressed. His mitochondria are monitored. The same person, different protocol, and entirely different nocturnal biology. The only variable is timing, with a few deliberate interventions costing less than $20 per month combined. That contrast is not hypothetical. It is the biological difference between someone whose cancer cell quality control cycle runs completely every night and someone whose cycle runs at about 40% of optimal over months, years, or decades of nights. How old are you? Please write it in the comments section right now. I'd like to know which age group makes up the majority of our viewers because the protocol I'm about to describe varies in specifics between 45, 60, and 75. Please include your age in the comments. Seriously, I read them. Now for the protocol. I call it the Mitochondrial Night Reset. 3 phases. The total active time per day is approximately 7 minutes. This is exactly how it works. Phase 1 is the eating cutoff protocol. This is the most structurally important phase because it determines whether AMPK is activated and the mitophagy window opens. The goal is to cut off all food 3 hours before your intended sleep time, not 2. If you go to bed at 10 p.m., your last calorie enters your body around 7 p.m. If you go to bed at 11 p.m., the cutoff time is 8 p.m. The reason for 3 hours rather than 2 is due to insulin kinetics following a mixed meal. Insulin levels peak approximately 60 to 90 minutes after food consumption and take another 60 to 90 minutes to clear at normal metabolic rates. If you eat at 9 p.m., when you fall asleep at 10:30 p.m., your insulin levels remain elevated. Elevated insulin suppresses glucagon, which suppresses AMPK, effectively closing the mitophagy window before it opens. 3 hours allows your insulin to fully clear and AMPK to begin activating in the early stages of sleep, which is precisely when mitophagy should be active. Modification for people with diabetes or hypoglycemia. Discuss this timing with your doctor before implementing it, as blood glucose management must be considered. For everyone else who does not meet those conditions, this is the protocol's most leveraged single change. The mitophagy window is open. It asks nothing but that you stop eating earlier. The water is fine. Herbal teas without honey or sugar are acceptable. The criterion is calories. Phase 2 involves darkness and temperature staging. Your pineal gland reacts to light suppression. This is not new information, but the implementation most people use is incorrect. Wearing blue light glasses at 9 p.m., sitting under overhead LED lighting is similar to wearing a filter on one lens, while the other eye is wide open. The research on melatonin suppression by light shows that intensity is just as important as wavelength. A bright white LED overhead light at 200 lux suppresses melatonin similarly to blue shifted light at lower intensities. This is phase 2 implementation. Beginning 90 minutes before your intended sleep time, reduce all overhead lighting in your environment by at least 75%. Use hip height lamps instead of ceiling lights. Use warm tone bulbs, 2700 Kelvin or lower, similar to the warm amber color of candlelight or an old incandescent bulb. Avoid holding screens up close to your face. A television 12 feet away with low brightness suppresses melatonin far less than a phone screen 6 inches from your eyes. The physics of light suppression revolves around photon density reaching the retina. Distance reduces it dramatically. With phase 2, you are engineering a 90-minute ramp down in your visual photon environment so that your pineal gland receives a clear darkness signal and begins peak melatonin production before you even go to bed. The second component of phase 2 is temperature. The core body temperature naturally drops as melatonin levels rise. If your bedroom is warm, above 68 degrees Fahrenheit, cooling is inhibited. The research on bedroom temperature and melatonin production consistently shows that the 65 to 68 degree range is ideal for adults over 55. Below 65, the sympathetic system will activate mildly to maintain core temperature, which can raise cortisol levels. Above 68, the core temperature drop that occurs with healthy melatonin production is reduced. Set your thermostat between 65 and 68 degrees. If you sleep with a partner who prefers different temperatures, a cooling mattress pad is a viable option, and several have been researched in the sleep literature specifically for this purpose. Phase 3 is the protocol's supplement component, which focuses on mitochondrial support. I want to be clear about what the evidence actually supports and what is merely plausible. 3 compounds have the strongest mechanistic links to the melatonin-mitochondria axis and the Warburg Effect suppression we've been discussing. First, there's melatonin, but not in the doses commonly found on supplement shelves. The majority of over-the-counter melatonin doses range from 1 to 3 milligrams. The pharmacology research on melatonin and mitochondrial protection, including Reiter's work, indicates that the doses with documented antioxidant and mitochondrial membrane effects are significantly higher, in the range of 5 to 10 milligrams for most adults over 60. The dose of 1 to 3 milligrams is primarily effective for shifting your circadian rhythm, which means moving your clock forward or backward. Higher doses appear to be more effective for direct mitochondrial protection. If you are taking any medications, consult your doctor before using this specific element, as melatonin interacts with blood thinners, diabetes medications, and some immunosuppressants. 5 to 10 milligrams of melatonin taken at your intended sleep time, not 30 minutes before, but exactly at bedtime, provides a pharmacological supplement to the signal that your pineal gland is no longer producing at adequate levels. You are not creating a dependency. Melatonin is not habit-forming in the clinical sense. You are correcting a deficiency. Second, coenzyme Q10, specifically the ubiquinol form, rather than the standard ubiquinone. CoQ10 is an essential component of the mitochondrial electron transport chain, the machinery that produces ATP. It is also one of the most powerful mitochondrial antioxidants known, working in tandem with melatonin to reduce reactive oxygen species accumulation within the mitochondria. The research into CoQ10 and cancer is complicated. I want to be cautious here, but the documented effect on mitochondrial membrane potential and oxidative defense is consistent across multiple trial populations. The ubiquinol form is more bioavailable, especially in people over 60, where the enzymatic conversion of ubiquinone to ubiquinol is less efficient. The most robust trials show that 200 milligrams of ubiquinol taken with your last meal is the optimal dose because it is fat-soluble and requires dietary fat for absorption. This is another topic to discuss with your doctor if you are taking statins, as statins deplete CoQ10, and some doctors will recommend supplementation proactively for this reason. Third, magnesium glycinate. Glycinate, not oxide or citrate. Magnesium is a cofactor in over 300 enzymatic reactions and plays an important role in mitochondrial function by directly influencing electron transport chain enzymes and ATP synthesis. However, its relevance to the night reset protocol is due to its effect on the HPA axis, or hypothalamic pituitary adrenal axis, which regulates cortisol production. Magnesium has been shown to reduce nocturnal cortisol elevations. A 2012 study in the journal Magnesium Research discovered that magnesium supplementation significantly reduced salivary cortisol at 11 p.m. Adults over the age of 50 suffering from insomnia. The glycinate form was chosen specifically because it is the best tolerated form for higher doses, 3 to 400 milligrams, without the gastrointestinal effects that citrate and oxide can cause. When taken 30 to 60 minutes before bed, glycinate binds to the same glycine receptor as inhibitory neurotransmitters, providing a mild anxiolytic anti-anxiety effect in addition to cortisol reduction. If elevated nocturnal cortisol is a major contributor to your specific pattern, this may be the most important of the 3 supplemental components. Subscribe to Doctor and hit like right now. We have nearly 50,000 subscribers, and this channel is based on one guiding principle. The research that will change your outcome is already available. It is simply not being translated for you. Each subscriber helps the next person find it. Now for the case callback. Robert. He approached the Mitochondrial Night Reset with skepticism. "I am an engineer," he informed the researcher. "I need to see the mechanism before I can trust the protocol." He'd just seen the mechanism. He implemented phase 1 that same week, shifting his dinner to 6:30 p.m. and eliminating his 9 p.m., completely consumed the evening snack. He implemented phase 2 3 days later when the new babies arrived. He began taking magnesium glycinate in week 2. In week 3, he increased the dose of melatonin after consulting with his integrative oncology team. By the end of the first week, it was 2 a.m. Wakefulness had decreased from 6 to 3 nights per week. By week 4, 1 per week, with occasional zeros. By the 3rd month, his morning energy had improved to the highest level he had experienced in 6 years. His 6-month oncology review revealed that PSA remained undetectable and inflammatory markers were at their lowest recorded levels. His cortisol tests, which were repeated after 3 months, revealed that the nocturnal pattern had normalized. Both at 11 p.m. and 2 a.m. readings were now within normal range. The researcher noted in the case file that this result was consistent with the protocol's predicted outcome, addressing all 3 simultaneous upstream failures that were documented at intake. Robert's words for the research team. "I spent 3 years thinking I was doing well because my PSA levels were normal. I had no idea what was going on every night as I slept. There is no billing code for prevention. Your oncologist will not walk you through the melatonin-mitochondria axis during a 12-minute follow-up visit." That's not a criticism. It is a structural reality of how the healthcare system distributes time and financial incentives. PSA monitoring is scheduled. Nocturnal mitochondrial quality control fails. The purpose of this channel is to fill that gap. Now, I'd like to be candid with you about 4 findings that should lead you to a doctor before implementing any of this. The findings indicate that you should not be watching a YouTube video right now. You should call your doctor today. First, unexplained weight loss of 10 pounds or more in the previous 3 months without an intentional dietary change. This pattern, combined with any cancer history, necessitates immediate evaluation. Not next week, today. Second, chronic, deep bone pain that is unrelated to joint problems, particularly in the spine, hips, or ribs. In a person with a history of cancer, bone pain in those areas cannot be treated with supplements. That's a red flag that requires imaging. Third, a sudden significant change in fatigue rather than gradual age-related tiredness, with you going from normal to profoundly exhausted in a matter of weeks. In the context of a cancer history, step-change fatigue requires further assessment. Fourth, persistent night sweats that soak your clothing or sheets with no obvious cause, such as hot flashes or infection. Drenching night sweats are a systemic immune signal that requires evaluation. If none of these apply to you, just breathe. You are not in a crisis. You're watching this video because you want to secure your future, and that is precisely the right instinct. The protocol I've just described is low-risk, evidence-based, and directly addresses the most mechanistically important nocturnal vulnerability in people over 60. You can breathe. However, the quality of that life is worth guarding carefully. A quick note on foods. Some of this is obvious, while others seem counterintuitive. The foods that are the most harmful to the melatonin-mitochondria axis at night cause the greatest and longest insulin response in the evening hours: white rice, bread, simple sugars, and alcohol. Alcohol is especially harmful because it directly suppresses melatonin production through a documented inhibitory effect on the enzyme that converts serotonin to melatonin in the pineal gland. One standard drink at 8 p.m. reduces melatonin production by roughly 20% during the critical midnight to 3 a.m. window. Two drinks at 8 p.m. increased by approximately 41%. The damage is dose-dependent and real. I'm not saying you should never drink. I'm describing the mechanism so you can make an informed decision about timing. Foods that support the melatonin-mitochondrial axis. Tart cherries are one of the few natural sources of melatonin with a significant concentration. A small study from the Louisiana State University Agricultural Center discovered that adults who consumed tart cherry juice for 2 weeks had significantly higher overnight urinary melatonin metabolites, not the same pharmacological effect as supplementation, but a genuine food-derived signal. Walnuts have some of the highest concentrations of melatonin of any whole food, despite their small size. A handful of walnuts at dinner, not as a nighttime snack, but as part of your final meal before the cutoff, helps to replenish the melatonin substrate pool. Fatty fish at dinner, such as salmon, mackerel, and sardines, contain omega-3s that support neuronal phospholipid membrane integrity in the pineal gland, which improves melatonin production efficiency. Consider it as maintenance on the factory that produces the compound you require the most at midnight. Here's your takeaway. Clean, simple, and actionable. Step 1. Implement the 3-hour eating limit tonight. Select a consistent bedtime. Count back 3 hours. That is your last calorie for the day. Step 2. Begin the 90-minute light ramp down at the time you've set. Reduce the brightness of the overhead lights. Change to warm-toned, low-height lamps. Move the screens to a distance. Set your bedroom temperature to 65 to 68 degrees Fahrenheit. Step 3. Begin taking magnesium glycinate 300 to 400 milligrams 30 to 60 minutes before bedtime. This is the lowest risk component of the supplement sequence, and it directly targets nocturnal cortisol. Step 4. Discuss with your doctor the addition of melatonin 5 to 10 milligrams at bedtime and ubiquinol CoQ10 at 200 milligrams with your last meal. These are the compounds with the strongest mechanistic support in the writers and mitochondrial oncology literature. Step 5. Reduce or significantly shift your alcohol consumption. If you drink, do it before 6 p.m. Alcohol's ability to suppress melatonin varies with time. Early consumption allows for faster recovery before the critical midnight melatonin window. If you have a history of cancer, unexplained fatigue, bone pain, or drenching night sweats, do not start a supplement regimen as your first step. Go see your oncologist or internist first. That is the critical path for the specific findings. Your mitochondria have been running unsupervised every night for years, not because you did anything wrong, but because the system that should have protected them, the melatonin signal from a calcified pineal gland, has been declining quietly without an announcement, a test, or a conversation in a doctor's office. The healthcare system does not benefit from preventing this decline. There are no procedure codes for pineal gland support. There is no protocol for monitoring nocturnal mitochondrial activity. There is only the published, available research with clear implications and the decision to act on it. I'm Doctor, and I've spent years watching this pattern emerge throughout the literature. The same sequence, the same upstream failures, and the same downstream consequences, all of which can be avoided with a structured, evidence-based intervention that requires no prescription, no procedure, and costs little more than a box of magnesium glycinate and a change in dinner timing. It requires an understanding of how your body works at night, as well as the discipline to apply that knowledge. The night isn't neutral. It never was. Your doctor will not walk you through the melatonin-mitochondria axis at your next appointment. A 12-minute office visit generates no revenue and has no allocated time. That is why this channel exists. Please let me know if this video touched your heart or inspired you to reflect on your own journey. Please share your thoughts in the comments section. If you found this video helpful, please subscribe to the channel, press the bell icon, and share it with a friend or loved one who may need this comfort.